I'm just giving people a few minutes to come into the room.
Welcome, and thank you for joining this webinar in the COVID-19 and Humanitarian Settings Exploring the Controversial Issues series, produced by the READY Initiative, the Johns Hopkins Center for Humanitarian Health, the Health and Humanitarian Crises Center at the London School of Hygiene and Tropical Medicine, and the Geneva Center of Humanitarian Studies. During the webinar, we encourage you to ask questions by using the Q&A feature directly in Zoom, and some of these questions will be addressed in the section following the panel discussion. Access to today's recording will be available after the webinar at ready-initiative.org and on the websites of the three universities. We also encourage you to visit the COVID-19 humanitarian platform at covid19humanitarian.com, which curates, analyzes, and interprets guidelines and interventions being implemented in a variety of humanitarian settings to prepare for, respond, and adapt to COVID-19. It is now my pleasure to introduce our moderator for today, from the London School of Hygiene and Tropical Medicine, Professor Heidi Larson.
Good morning or afternoon, depending on where you live. I'm Heidi Larson, and I understand we're going to actually kick off before we really kick off with a quick poll, Ryan. If all of you could participate in this, and we'll see we'll take the pulse of our audience today in terms of their willingness to take one of the new COVID vaccines, only the approved ones. Great. This is about the level of India. We do global polling around the world, and India is probably about 86%. So, well, we have a pretty diverse audience though, so that's great news. Okay, well, just to kick off, since we have a fantastic lineup of panelists today and only an hour. I have the pleasure to, I'm not going to get into lengthy bios with anyone. I think they are all available on the website, but I will introduce by title. We're going to start with Colette Selman at Gavi, one of the regional directors of and to ask Colette to tell us about the COVAX facility. Gavi is a big player, a key player in what is called the COVAX facility, and to tell us a bit about the mechanism and how it can help make COVID vaccines potentially accessible in humanitarian settings, and perhaps especially for humanitarian, or in addition for humanitarian workers. Apologies.
Thank you very much, Heidi, and thank you very much for having the opportunity to be a part of this important discussion. So yeah, what is COVAX? So maybe start with that. So this is really a facility which has been set up to pool demand of countries for COVID vaccine and to purchase, on behalf of them, with the idea that we can ensure equitable access to and distribution of this vaccine across the world. It's a unique global collaboration. It's really a joint effort between governments, manufacturers, UNICEF, World Bank, civil societies, and many others to ensure that countries do have access regardless of the levels of income. And this is a very important point. What it does is it actually brings together countries which can self-finance these vaccines, as well as countries which cannot. And so the barriers of access are being removed. And the low and lower middle income countries are being supported, with donor funds behind this. So we have an incredible buy-in right now, with more than 189 economies and countries having signed up. And the reason, of course, why this is so important is that we have to ensure that everyone is safe. This is really the global response to any vaccine nationalism that we also see, has come up in this current situation. We also know that I think from recent research and modeling that we can really prevent twice as many deaths if we ensure that vaccines are, globally and equitably distributed. And the economic impact of the pandemic as well will be much, less if we ensure that all countries have access. So in terms of how does it, actually work? So first of all, the platform is, is there to support research, the manufacturing of vaccines. It pulls demand and negotiates, of course, also pricing of the vaccines on behalf of the participants. And important to note also is that the COVAX facility has the largest and most diverse portfolio of vaccines. So of course, we need to make sure that they're secure and safe. And so we follow all the, all the guidelines and protocols around that. And that's, again, an added benefit of this facility. So the initial goal is really in the context of limited supply of vaccine is to obtain at least 2 billion vaccine doses by the end of 2021. And that would be enough to vaccinate 20% of populations of countries that are part of COVAX. That would be an important start to end the acute, phase of the pandemic. Now we are expecting that the first, let's say, doses of vaccines will be allocated now in Q1 of 2021. And so countries are working very hard to really get ready. And that, includes a number of steps. So first of all, WHO has provided a roadmap for prioritizing the use of COVID-19 vaccines in the context of limited supply. And so countries are working, around that. So prioritization meaning, as you mentioned, health workers which are at high risk. Of course, we would like to see countries, including health workers, which are working in either, fragile settings or humanitarian, context, within these countries. The second is that, of course, in terms of prioritization and priority groups, are those with comorbidities and those who are specifically vulnerable and high at risk. And again, here we should imagine, those who are living in extreme poverty, refugee population, internally displaced. So countries are very much asked to, prioritize these groups because they are at higher risk of infection. Now, all of that needs to then be, worked out in terms of a vaccine deployment plan. And so that's really where we are sitting right now with countries, is to, make sure that they work on that. And against the readiness of these deployment plans, which includes the service delivery mechanisms, we would, be able to allocate vaccines once they become available. So in principle, we very much, of course, want to ensure that these vaccine deployment plans really reflect the right way of getting the vaccines to the end user. And this is, I think, where we all need to work together. It's extremely important that we get all actors around the table to help countries to develop these plans, because the vaccines will not distribute by themselves. And we know there are many, many obstacles to reaching, in particular, those who are forcibly displaced, those who live in perhaps in urban slums, those who live in refugee camps, or those who fall potentially through the crack. So in addition, to this approach, the Gavi board is also looking at an additional type of COVAX buffer. They are meeting next week to discuss this, where we would ensure access to COVID vaccines for high-risk populations in humanitarian settings that may not be covered in these national vaccine deployment plans. So that's very important. We want to set doses aside to secure that access and availability. And the intent would be to keep that buffer separate and make it open to both states and non-state actors, to apply for that. So maybe a final point around this is that we are also at Gavi quite excited that we're entering into new partnerships with humanitarian actors. As we all know, Gavi has made great, progress with countries and partners in the overall, goal of leaving no one behind and immunization for all children. We also know that a lot of the populations which have been disproportionately affected by having lack of access to health services are those who are refugees or forcibly displaced. And so we've been looking at partnerships with new partners such as IFRC, IOM, the IRC, International Rescue Committee, and hopefully soon also with Save the Children, UNHCR, and others, such as UNOPS, to really ensure that we have the right partnerships in place to reach these missed communities and vulnerable communities. So maybe I leave it at this point, Heidi.
Great, that's hugely helpful. Thanks so much, and I think has given a good kickoff to now talking a bit more about on the ground and what we're seeing at regional and country level. I'm going to turn now to Dr. Yodi Alakija, who was former humanitarian coordinator in Nigeria and has worked globally on these issues, as well as nationally and regionally in Africa. Over to you, Yodi.
Thank you very much, Heidi, and it's a pleasure to be here with all of you discussing such a critical topic, which is very dear to my heart. It's good to hear Colette talk about Gavi and talk about the facility and get that sort of overall look at how that affects the countries of the world. And also very, very glad to hear that there is more talk next year about, sort of later next week, about addressing more directly the topic of this seminar, which is those in displaced populations and humanitarian settings. However, you know, even before I get into the meat of my conversation, even as you speak, I know from practical experience here on the ground in Nigeria, and I'm in Abuja right now, and was actually involved in some conversations last week around some of the Gavi teams that came to Nigeria, that these are very much headquarter discussions. And we had a little talk about decolonization about a minute ago. And we have to accept at this point, because I know a lot of the people listening are based in Geneva, many other capitals of the world, that already we're having a them and us situation. So my key words around the vaccine already are around equity and access. We're already beginning to create a situation, the haves and the have-nots, those who are going to be able to access this vaccine and those who are not. Already we're hearing that 14% of the world's population have secured 53% of the vaccine. 96% of doses have been bought, the ones already available have been bought by the West. This is before people in low and middle income countries in Africa and Asia have even begun to have discussions around it. Now, I know that we were all caught pleasantly by surprise by the speed with which this came about and by the speed with which, you know, the vaccines were developed. And also something you didn't mention, which gives me some comfort, Colette, is the fact that I know that the Pfizer-BioNTech vaccine, which is, you know, minus 80 degrees cold storage, is actually not part of your COVAX facility. So hopefully that means that we have access to the rest that are to come, which might be more in line with sort of the countries that have really limited logistics. However, the low middle income countries are already beginning to fall behind. There is too much focus on the primary sort of populations that we see on CNN and Al Jazeera and what have you every day. There's too much focus on America and Europe and Canada and those parts of the world, and too little focus on the low middle income countries. Perhaps there's a narrative that it hasn't affected low middle income countries as much as it has the rest of the world. But then my question over the last few months to those who work, colleagues who work in ICRC and, you know, MSF and other organizations that deal directly with displaced populations is, what are we seeing in terms of COVID infection in these populations? Is anybody measuring it? And the first thing I would say to all of us is that there's no data. There is almost no data. For Nigeria, for instance, at the very beginning, I know that IOM built sort of isolation shelters for those who they thought might be infected. But because they're so overwhelmed, because we're only spending less than maybe $30 per person for the entire humanitarian response in a country like Nigeria, where we have over 10.2 million people who are in daily need of humanitarian assistance. We have 24 million affected. That is Nigeria alone. And we have 2-point-something million IDPs. Outside of the immediate shores of Nigeria, we have about 600,000 to 700,000 refugees in the Lake Chad region. So when we begin to talk about access to vaccines, I have dealt, I'm currently working at government level, at the highest level of our government, with those who are dealing with the immediate the immediate sort of COVID response, the national COVID response. When you say, well, what is going on in humanitarian settings? Unfortunately, I literally just get a laugh, because people are saying to me that we haven't even managed to feed those people. We haven't managed to provide basic health care. So how on earth are we going to get vaccines to them? IOM, ICRC, etc., are telling me that there is just, it's so difficult. Access is such a difficult issue, humanitarian access that is, that it's very difficult for them to know how many people in those places are actually affected. So how are we going to vaccinate them? How are we going to make sure that a vaccine gets to somebody who cannot get a plate of food a day? How are we going to make sure that the issues around the funding for me would be number one, the logistics would be number two, and then the collaboration. You know, Colette, you mentioned partnerships with IFRC, IRC, IOM, Save the Children, and many others. But we all know, those of us on the call, you didn't mention directly WHO, but you know, I will mention WHO because on this, I know that on this call is a colleague with whom, Jorge Castillo, with whom I worked very closely to vaccinate about 1 million people in Nigeria in record, you know, what I guess they call in America these days, warp speed time of about 4 weeks when we had a cholera outbreak in 2017. I know what that took. I know the level of collaboration. I know the level of dedicated funding, and I know the high-level political will that it took to do that. But we currently have a situation with displaced populations where the entire world feels like it's a crisis situation. You know, so nobody's particularly focused on Nigeria's crisis because everybody's focused on everybody else's crisis. Nobody's focused on the crisis in Central African Republic because the whole world is a hotspot. So we have a real challenge at the moment in ensuring all of us who, and this is a great topic to begin to discuss in these early stages, so that people are not left behind. Because I'm afraid that the major populations of the low middle income countries, you know, in the capitals of Ghana, of Delhi, of Karachi, of, you know, Lagos, Abuja, already the poor people, the people living in slums, who you can also call to an extent displaced, not necessarily by crisis, are already going to be left behind. If you know, it's interesting to hear you say that 20% of population is what COVAX facility is looking at having available by 2021. So that again tells me we have a narrative issue, because when I talk to the Nigerian government, their understanding from you and from the WHO is that, well, only 20% of the population needs to be vaccinated. So there's a lot of work to do, and I'm going to leave it there so that we can get into a discussion. But there's a lot of work to do from all ends of the world. My other half of the world is the Asia Pacific region, where there are people displaced by climate crisis. There are people who are having to leave their island homes and move to other places. How are they going to be vaccinated? They've had more an economic pandemic than a health pandemic because they have dealt with it, you know, by closing the borders, and they have practiced exclusion quite well. But how are we going to ensure that we rebuild those communities over?
Let's see, after saying thank you, Yodi. Well, you certainly laid out the challenges ahead, and I do think the perception, the timing issue is one that there's a lot of questions of in general, not just, I mean, in all countries. There's been so much focus on the news of the day that publics don't quite understand you know, just because the UK, I'm sitting in the UK, and yesterday was the big first day of a vaccination, but people don't know, don't have the full story, and we're not telling enough of the story to come and giving that kind of a narrative to bring people along with, because I think there's a lot of, I mean, it's been a very difficult and information lean on the one hand and information flooded on the other. But I think one of the things that we need to do is work with getting a timeline. And Colette, you said it the most clear that I've heard it in terms of what actually is the timeline. And I think that's a really important thing to keep in mind. But also a reality check for countries and what they need to prepare for. I'm going to move now to Dr. Chowdhury. We're moving from global to regional, but not just regional, I mean, to some of the national issues and challenges, to Dr. Chowdhury with Brac in one of the widely known and really prize-winning, if you can call that, NGOs on the ground, and just to talk to us about the situation in Bangladesh and just where you're doing a lot of important work at a community level in particular around the whole COVID response. And how do you see your role and the situation in Bangladesh in terms of anticipating and supporting a rollout of vaccination?
Thank you for having me and giving me the opportunity to talk to this esteemed forum. In Bangladesh, since the detection of first case in March 8, altogether around 500,000 individuals had been identified with COVID symptoms so far. And it claimed around 7,000 deaths and lives. Though it's already we know that it's hugely underreported because you know that the most reports are coming from the capital city and big cities. So while government is doing its best to curb the transmission, like during lockdowns, there is a huge impact on the people's lives, especially on economic and social activities. And also it disrupted the health system hugely. And we could see that the essential services like maternity care, family planning, immunization, and were hugely underutilized during March to June, and now it's now taking off. But still, it's the health system is struggling to get into where it was, because there were two reasons. One is that people are not confident enough to take services from there, and second is that our health system is not ready to tackle with this new emerging disease. I think all health system is also struggling to do that. So as a result, vulnerable groups like women, children, newborns, adolescents, persons with disabilities were mostly affected. So at present, our country is community transmission stage, and there is no mechanism in place at scale for case identification and management at community level. So what Brac has done here, that Brac, the very first day, Brac started to working with government in all aspects, especially in risk communication and also case identification and sample collection. So the risk communication, where Brac played a great role is that ensuring mask wearing for everyone, and that's mostly our activities were through our health workers, because the health workers is the backbone of Brac health system. And currently we have around 50,000 health workers across the country, and they are distributed all 64 districts. On top of that, what we have done during the COVID time, we have also other community workers. For example, we have school teachers and we have other community workers, and we have also trained them on COVID preventive activities and also what to do if they have COVID-like symptoms. So like very basic things, and then those altogether, those 100,000 community workers, they visited by this time almost half of the total country households, and they distributed COVID messages and stickers and posters on awareness on COVID prevention and control. So these are the activities, and on top of that, we are also doing helping government in sample collection, especially in areas where people don't have access, because most of our sample collection activities are located in the big hospitals. But Brac has established sample collection booths and in the community places. So it's like in the community, like schools and in the community centers. So this help people to have better access to sample collection, and also our health workers raise awareness on like testing. But still the testing is very low in our country. So currently we are covering 110 million population through our health activities. That means that health workers are reaching them every day through the household visits, and we are taking the opportunity to transmit the messages through this platform. So if I just give you an example, that we have created a community support team in Dhaka city, where the infection is mostly identified and clustered. So here the community support teams are working in poor like slum areas and non-slum areas, and so far, like over 5 months, they have identified, they have visited altogether 155,000 probable cases like with symptoms. Those have made either phone calls to national household visits, and through these visits they have syndromically identified almost 40,000 COVID-like cases and provided them home care. And also through WFP is a food support program, we have provided food support to 27,000 of the households, because they are very poor, so they can maintain 15 days quarantine with their families. So that a glimpse of where we are also working with the Rohingya communities from the day they are coming in. So there we have 11 health centers, and we have couple of hundreds health workers, community health workers, and they are raising awareness and also identifying probable cases and sending them to the health centers for testing. So I will now go for like why, how Brac can play a role in vaccination process. Because vaccination, if I start with the history, in 80s when Bangladesh first introduced a EPI vaccination for children, at that time the vaccination uptake rate was only 2%. And at that time we had 6 divisions, and then government talked to Brac and other civil society and distributed the divisions into different, like 2 divisions to Brac and 2 divisions to other NGO, and 2 divisions the government worked alone. And where Brac worked in a couple of years, the vaccination uptake rate went from 2% to 80%. So that means what Brac did was that the communication, because Brac had a very good numbers of health workers who have been identified from the community, and they work from the community, and they they know that what are the barriers and of uptake of the vaccination. So here the same thing will be like applicable. Like for promotion of this vaccine, there are lots of rumors around COVID already going on here. I don't know how much you know, but the COVID with vaccine, we are anticipating that there will be rumors again around this vaccine. So if we have to tackle these rumors, then we have to do like proper communication with community, and one-to-one, and sometimes with the community, and for informed decision, that is very much needed. And as this our community health workers has a very good understanding of the local context and socio-cultural factors impacting healthcare access and uptaking, so they can play a crucial role here to increase the uptake of the vaccination. And the second thing is that adherence and compliance with the vaccination. And this is not a single dose vaccine, this is multiple dose. So they have to continue the vaccine, right? So for this, someone has to track, and there is no such system in Bangladesh to track people that who like no electronic database to track people that who have taken vaccine and who are lost from due date. So here again, Brac can play a role, because Brac is developing a database for their beneficiaries, and Brac can utilize that database for this to track that who are dropping off when from the due dates. So that is one thing. And another thing is that there are some barriers against adherence to vaccination, so they can identify, and we can also launch another set of communication that to overcome those barriers. And the third thing is that vaccine administration. So if it is not institutional vaccination, if it is a community vaccination, then the health workers can easily be trained and put put in a team to help in and give a vaccination process, because they are in great number. And the fourth thing is that data management and MIS system. And as I told you, that there is no database currently regarding the age pattern and the comorbidity pattern to prioritize that who are eligible for this vaccination. It is difficult for us to prioritize. So there is some sort of mechanism needed to identify those people, those 20% or 30% who are going to get this vaccine, so and identify from the community in equitable manner, right? So if you provide this vaccine to someone and it's their purview to just subjectively identify people and put vaccine, and that we can't expect that is going to be equitable. And the third thing, fifth thing is that monitoring. So everything can be done, but there should be a great, strong monitoring system, that those who are going to get it, they are getting it, and that the quality of the care, that if there is any kind of complication happening, that is reported correctly and that is addressed correctly. So that things should be also can be done by Brac, because Brac has a good network in the community, not only health worker but the supervisors. And the other thing is that the MIS system can be also, we need this MIS system because we have to know that how much, what is the side effects, how long the immunity it gives, and there are many things we have to know regarding this vaccine. So this data is very valuable for us to preserve. And the last thing is supply chain management. And Brac has helped government previously in developing the capacity of supply chain management previously. And I think this time Brac can also help in supply chain management process, because this is a very tough thing, and for government alone, this would be a very difficult thing. So all parties can play together. And last but not the least, our humanitarian experience. Brac has extensive experience working in humanitarian crisis. Brac is one of the largest service provider in Rohingya refugee camp in Bangladesh, building an array of services from scratch to meet the needs of the nearly 1 million residents. During the Ebola epidemic in West Africa, Brac radically altered its protocols to ensure its staff and CHWs are providing necessary support and infection prevention control measures required to reduce disease transmission. So that that's what I have to say about Brac, that how it can play a role in a vaccine administration in Bangladesh. Thank you.
Thanks so much, Dr. Chowdhury. That was a fantastic overview and really gave a really important perspective on the ground. And I know Brac has a long history working closely with government, but you raised a number of important points. And the one that really struck me was also really the importance of trust and local trust and understanding the local environment, which is really crucial. Now I'm thrilled to introduce Joanne Liu, who was former president of Médecins Sans Frontières and is now a frontline emergency physician, or has been before, but now working in Canada, and really to give us your perspective from your extensive global experience, but also yourself as a frontline healthcare professional. Thanks so much.
Hello, everybody, and thank you very much for having me here. So I'm going to do a sort of a short intervention just to make sure that we have room for some questions. But I think, at the outset, I would like to just echo some of what Dr. Chowdhury said, is the fact that the effectiveness of a response really rests on whether communities, people perceive it as legitimate and trustworthy. And so if it's not the case, then it becomes a very, very difficult, I would say, exercise. And then if we translate that into epidemics in conflict zone, then we have a bit of a lethal combination. And I think we've seen some of that, with Ebola in DRC in the last few years, where it got very, very challenging. So when we talk about humanitarian, I would say, setup, I think that we have the displaced people. We can think of people in detention center, in places that have been quite somehow under the news in Libya, this detention center. But population on the move, we have population in the move in countries, but we have as well in displaced population in what I call the non-state actor controlled territories. And what happened with those people? So we think that it represents about 60 million people, and then how are we going to get access to those people who are not part of I will say recognized country? And I'm glad to hear from Colette that COVAX will keep I will say a buffer for those population that are from non-state actor. On the other hand, we know how how tricky it is and how complex it is. Is we know that to access them, it's going to be an issue, because right now COVAX is built on going through government. So we're going to need to go through other type of I would say, negotiation. Who's going to do the negotiation? How do we deal with non-state actors? And we know in some places where it's been very, very difficult, that vaccination, this huge pushback. Some of my friends have, and I quote, this person said there's some anti-vax community on steroids in some countries, some part of the world, you know, and we've seen it in Pakistan and in Afghanistan, where polio vaccinator have been killed. So what is the world plan to reach those people? And who's going to make the negotiation? And who's going to make sure that it's possible? And will the world come together? Because the idea is to not have any large pocket of population that is not vaccinated, because until everybody is protected from COVID-19, we're still going to be, all of us, at risk. And so so there's this is one issue. The other issue is the fact that we still have not resolved the idea of aid being perceived as support to what we call label group as terrorists. And there was a resolution at the UN, the 2462, that didn't give exemption to humanitarian aid or medical aid. And therefore it's considered as a support to terrorist groups. So how are we going to manage that? How are we going to navigate those very, very difficult circumstances? So so that's, and then my third point is we're talking about COVAX and other mechanisms. We're talking about vaccine nationalisms, and it's all true. On the other hand, there is a bit of a parallel world where vaccine has been developed in two countries, like China and Russia, and they are right now thinking of sharing, you know, this their good of vaccine, and like Russia to Venezuela, for example. China already, you know, sold to Dubai, and so how do we factor this in, and are we going to as well factor the fact that there are some countries that that have over pre-order vaccine? I'm come from a country that apparently there's about an average of 10 vaccines per citizen. And so therefore we might go from vaccine nationalism to vaccine imperialisms. So how are we going to do that? These are questions that I have no answer yet for, but I think that we have, it's an uphill battle. It's going to be a huge challenge, but I think it's going to be the acid test, or how globally do we enact solidarity in times of, I would say, an existential global threat to the world. I'll stop there.
Thanks so much, Joanne. That was really all important points, and I think the issue of vaccine imperialism is quite a good. That's definitely a soundbite to remember and to be worried about. Actually, I've also seen that India has got 100 million doses of Sputniks from Russia, and Indonesia is about to roll out the, they say the Minister of Finance in end of December to start with Sinovac from China. So in the absence, especially recognizing that COVAX will support, and by later in 20%, I know even the CDC is recognizing that there need to be other ways, other negotiations, because you know, to get to the needed 60-70%, we still have quite a bit of work to do. Although it's, you know, it's fantastic that there is the facility that is there. There's at least that. So that's, but how can we build on that? There have been a number of different questions. Certainly the misinformation point has come up from a couple of people, how to deal with that. I think, I mean, I'll turn that one to Dr. Chowdhury being on the ground, but I do think that I do a lot in this area myself in our research group, the Vaccine Confidence Project, and we are really, although we work very closely with a number of the big social media platforms, we really recognize that there's a whole cascade that we need to look at from at the level that you're looking at in Bangladesh with the door-to-door, person-to-person. We can't lose sight that these social media platforms, you could shut half of them down and we'd still have the problem. It would move around in different ways. So we need to have multiple interventions think of the bigger information ecosystem. But Dr. Chaudhry, do you have any comments on that?
Yeah, Heidi, you are right that only one way of communication is not enough. We are also doing social media, but as I am mentioning community channels because that is most powerful, but that should be supported by other channels as well. Like social media is one, and also the influential persons, religious leaders, that is also very effective. So we are using all platforms, but health workers are the most important one because they are very close to the community and they can answer all the questions, and that could be very interactive. But for social media, many people, most of our people can't use social media and now still can't use, and they don't have access to internet. So the major channel of communication is still the person who can reach in the villages. So either miking or in the mosques when the sermons. So those things are very powerful and very influential. And the influential persons, they trust and believe most. And doctors can also play a role here because doctors are sometimes a role model here. So yeah, that's multiple media is very important.
Thanks. One of the questions that's come up, and I know that there's the meeting next week with the Gavi board, but I think this is more for Colette on are humanitarian organizations expected to be procuring their own vaccines because they're not a nation state or outside of COVAX, and just I don't know if that's one of the topics for next week, but what is the guidance coming from COVAX for non-state actors, as Joanne was raising also?
Yeah, thank you for that. So the Gavi board so far in terms of how the facility is set up is focused on countries and economies. So it is the countries and economies which have joined the facility. The COVAX buffer that I was alluding to, which would be discussed, next week, I think there what we would look at is to see in cases where certain populations or groups fall through the cracks, who could reach them, and then allow non-state actors to act on their behalf, and so to access the vaccines and make sure we get them to these populations. So of course, we're still dealing in a limited supply situation, and this is also why the board is has been focusing on that equity part between countries to start with. And again, as said, our expectation and hope is that we could manage to reach this 20% of population being covered in the course of 21, but of course that is the start. So at one point over the course of 2022 and the years to come, we hope this, of course, the supply of vaccine will become stabilized and overall available with prices which go down, etc., and becomes a normal part of a vaccine program. So yeah.
That's great. I mean, that's a helpful framing, I should say. Yodi, from a kind of country perspective, I mean, coming from the global discussion to the country, do you have any comments on this?
Yeah, I'm looking at the sort of question right now about humanitarian workers, and I think it also links into some of what Joanne had said earlier. Number one, it's going to depend country by country on what the government allows. And it's going to, I mean, there was a question in the chat earlier, which I'll also answer at the same time, which somebody said, are humanitarian workers going to be expected to go back to their own countries to be vaccinated, or will they be able to be vaccinated in the country in which they're working? I don't think it's impossible almost to overstate how complex this entire operation is going to be, because of some of the logistical challenges, the cold chain issues, that are going to be associated with getting vaccines into what we call deep field, in those really hard to reach places. Joanne, I'm sure she'll mention this again, has also talked about those, as Colette also said, who fall between the cracks. I mean, we have a situation in Nigeria where in many communities, you don't know who is ISIS West Africa or who is a member of the community. And so, how do we delineate if we have to delineate? There needs to be a much larger conversation around vaccine distribution and vaccine access to those in these vulnerable populations and situations. Dr. Chowdhury talked about testing, which is another critical issue. If we think about how many have been tested in humanitarian settings, displaced people, refugees, IDPs. I mean, the work of Brac has been much lauded here. They've done a fantastic job, and she talks about how they have low testing numbers. I can say, for instance, in Nigeria, the testing is almost non-existent for people in humanitarian settings, for IDPs, also in the wider Lake Chad region, in the Central African Republic, in Mali. Nobody is testing. So how are we going to get vaccines to them? I think local context is going to be really important, but I think international collaboration is going to be the absolute key. And, we're going to have to go very much to, I mean, I don't want to borrow the next topic, but decolonizing this and making sure that Gavi at headquarters is working much more closely with people on the ground, and so that they understand what the challenges are, because it's going to be very difficult to determine or even to answer some of these questions that I see, Colette and others being asked. It's very difficult for them to answer if you're not on the ground in these countries or have worked within these contexts. Humanitarian workers, I would like to advocate up front here, have been seen as, well, first of all, I'd like to advocate that they are top of the list as well for vaccinations, because they're also being targeted. I know in Nigeria, and I know in the wider Lake Chad region, at the beginning of the COVID crisis, most humanitarian workers had to leave because it was an imported disease, quote unquote, and they were being seen as vectors. So that would be my contribution to that little piece.
Great, thanks very much. And just to add it to some of those challenges are the fact that these vaccines are 2 doses, and the issues of getting people back for a second dose, which is a month or 6 weeks later, and the issues of identification to make sure, particularly in a humanitarian setting, are you getting back the same person? My group worked a lot in the multi-country Ebola trials, and it was quite a engagement process, and you need to stay in touch with these people during that interim period or you've lost them. I know that there is a potential J&J vaccine on the horizon that is looking good. That will be 1 dose, so that will be helpful, but we're not there yet, but that's something to look forward to. Just for a last comment, let me, since others have had a chance to talk, maybe Joanne, could you contribute here?
Sure. I think that all the points that's been, raised are all well taken, and I think that we should not minimize the difficulty that it would represent to go in conflict area, and especially in conflict area that are controlled by armed non-state actors that are labeled as terrorists, and because this is something that's going to be difficult. We've seen it, in northeastern Syria, how hard it was to cross vaccine during the little polio outbreak, and how much it still continued to be a challenge. So there's going to need to be some sort of what I call humanitarian health diplomacy to kick in at one point, to facilitate some of those channel and conduit to get things to be done, and then to create a bit of a protection. But that being said, it's going to be relying on people who know how to negotiate with those groups, people who have a sort of a what I call sympathy or confidence capital with those groups. And it can be only newcomers. We've seen it, DRC was such, I would say, a humility lessons about being able to vaccinate. And so many WHO, as much as MSF and other organizations, got under the fire. So I think that we're going to need to come together. I don't think that just only having a conversation, a platform is going to be enough. The legwork is going to be difficult. We're going to need to go and reach out to negotiator, health diplomacy negotiator who knows how to do it. Nobody should improvise them to do that. And we're going to need to get some sort of acceptance of immunity from the rest of the world, that if you are to go and give a plan of vaccination and help to vaccinate in a labeled area as terrorist, that there's an exemption, that you cannot be liable of supporting terrorist group. And that needs to be clear at the outset. Otherwise, I think there are going to be only a few people that we want to take up that task.
Thanks very much. I think that's actually a really important note to wrap up on. I know in the years of work I did with UNICEF around vaccination, vaccines used to be kind of a soft diplomacy where, the warring sides would put down their guns for the one day you'd go in and have a kind of zone of peace while you vaccinated, but those times are over in a sense, because it's not always clear who's who in the current setting. Even where you say, well, this is Taliban, this is not. Well, there's multiple different factors, sectors and sects and groups within these groups. So it's a much more complex environment, and where you don't know who's who. So I do think this immunity, as it were, will be important to move forward and in this situation. We have just 2 minutes. If anyone has any last comments.
Yeah, if I could come in.
Yes, thanks, Colette.
Thank you very much, Heidi. And just to say, I really appreciate that, all the points which were made, and I think they're incredibly important. To me, it also shows that there's no way any organization by itself can make this happen. I think the challenges which were mentioned today are the challenges we have been facing, as was outlined, I think, from my colleague from Brac, around immunization for children are very similar to the ones we were, discussing today. And we made enormous progress, but at the same time, we've also seen exactly, where we are still falling short. And so working with local organizations, working with the right humanitarian actors, I think, as was outlined, making sure that we better communicate, that we understand this is I think one of the unprecedented, global tasks that we're all facing. I think, is really good, to understand, and only through really this partnership at international, but definitely at global and subnational and down to the level where the communities are. That's where we need to make the change. So thank you for that, and all very helpful for us to keep in mind for the next steps. And finally, I do think that we're not talking about the future, we're talking about now. We really need to all bring this together over the coming months to come. So thank you very much.
Great, thanks so much. And just in the last minute here, I just want to thank all of the panelists. This has been really rich and important. I mean, so many issues have been raised. It's we need more time to really think through this, but there is an opportunity for some of these to be brought up in the next humanitarian webinar, which will be Wednesday, January 13th, same time. And the topic will be, how has COVID-19 accelerated the humanitarian sector's commitments to decolonize decolonize aid or not. Thanks to everyone, and stay safe, and thanks for participating today.
So much.
Thank you very much. Have a
Good
good day.
day.
Bye.